Hello everyone, this is just this next 15-20 minutes we're just going to go over an abbreviated version of what we went through next in our workshop for our supervisors, and the focus here was how to actually acquire the best available evidence and how to read a paper. And this is a very abbreviated version. The focus here is going to be more about our teaching methods of evidence-based medicine rather than the content itself. But for those that do want to learn about the content, we've got it up on a YouTube clip, and we can put it on after the and make it available for you. So this is what we're up against. We had these GP supervisor workshops. People aren't here specifically to learn about evidence-based medicine, so there's going to be a lot of people who are either sceptical or disinterested, and so we need to get a bit of buy-in. And the way we did a bit of buy-in was essentially we used the role play as the case, and then we asked people, having introduced the evidence-based triad, which aspect of this triad would you actually use to make a decision on a patient? And we put out a few different scenarios. We imagined a scenario where, for example, the patient was really keen to use acidophilus, and so that's where the patient values was a big feature. And would evidence base have any role here? And I thought that people would come out from the audience would be that, well, maybe just to make sure that to know what side effects there are at least of this of the acidophilus. Another case example we give is an immunosuppressed patient, and who's contemplating acidophilus, and how that's a piece of that by our clinical expertise we know that immunosuppression could be an issue if you're taking a bacteria as a therapy, because you might get an opportunistic bacterial infection. So, in that case, the best available evidence, the role there might be, a particular role might be about whether there's any rare opportunistic infections of catching the probiotic from taking the probiotic. So we sort of played around with it. But then we'd have the situation, well, the patient really just would like to know, is it likely to work or not? In which case we really want to know that question. And then that brought us to a different type of question that we'd ask people is we turn around to the audience and say, well, who in this room has actually seen enough cases from their clinical experience to know if acidophilus actually improves any symptoms of irritable bowel syndrome? And the usual answer is no. And I guess that's the way of helping people realise that there is a role for evidence-based medicine, even if you're a bit reluctant about it, and that it sometimes finds a truth that it cannot be obtained any other way. And then we can go to other examples like smoking and so forth. So that's sort of part of our buy-in. We then divide this talk into two parts. One is how to actually find the evidence, and the other one is how to read a paper. To find the evidence, we're not going to focus on that in this 15-20 minute presentation, but as I said, there's a YouTube clip if you want to get the full detail of what we did. But essentially, we got people to start thinking about working out what's the question type you are asking. What's this type of question you've got about, in this case, Jack and his irritable bowel and whether acidophilus helps. And because the point is that will dictate what study design is going to best answer your question. And the other thing we ask people to start trying to do is work out what's the PICO of the question they've got about Jack, because knowing the study design that's going to best answer the question and the PICO forms the basis of how we search for the best available evidence. And we use different examples of question types. So we have questions. I'll just give you an example. We'll give an example: why that behaviour, attitudes and beliefs, and point out the best type of available evidence to answer that is qualitative research. And to get a bit of buy-in, what we did is for each example we gave of like this, we would use a real-life example that the GP could relate to. So in this area, LA bicillin for rheumatic heart disease is a really common thing, or GPs are familiar with that. They all have problems with getting people to take their LA bicillins. So I drew on a question that came from my own health services perspective, which was we wanted to know what are our barriers for people taking it. And we found a qualitative research study that showed that actually in our area that there's a pattern of migration that's very predictable between three communities that Aboriginal people in our area tend to go to, and that it's in a predictable direction. And that was very useful information that we obtained to change our practice. And so what we're doing by using these examples is trying to buy the GPs on side so they could see the rationale of this and how it's relevant locally to them. So we did that with qualitative research. We went through questions on quantitative questions and what sort of studies best answer those, and gave some personal examples of that. And then we just did the same with the more complex types of questions, such as therapy, etiology, diagnostic and prognostic questions, and showed what sort of studies would best answer those questions. And then we finished up with this slide, which I should really give credit to the group from New South Wales who ran a workshop last year for RSCGP, this slide. But basically, we started to get across this concept that, for these complex, that for your different question type, which I've got in arrows, there's a rank order of what type of study design is going to best answer your question. And what we're trying to get across is a few fundamental things. One is that, this concept that randomized controlled trials is the top of the pile is not true, that it depends what question type you have. And so here for a treatment question, yes, it is close to the top of the pile. But for an etiology question, realistically, probably a prospective cohort study. So that was one thing. And then what we did is just to challenge people a bit, we said that for a therapy question, we said that expert opinion is considered at the bottom of the pile. How do people feel about that? And it was to really suck people in and get those arguments happening. But what we're trying to make the point about is that in the evidence-based triad, expert opinion has its own probably rank order, and an expert, our clinical expertise has its own rank order, and that an expert opinion is worth gold in that setting. It's just that in this narrow area of therapy questions, in the evidence, in the domain of best available evidence, that part of the triad, it's not. But that's okay, because it doesn't mean it's. So the point is that we didn't want to de-threaten this whole idea of hierarchy. The only other thing we got out of this that we wanted to bring out was to equate levels of evidence, so that you could work out what's your question type, what's the study design, and based on that, what's your level of evidence. So that were the things we wanted to get out here. We then focused on the PICO of Jack, and we personalised it to Jack. So, that Jack is a man with is a man with diarrhea predominant irritable bowel. He's a middle-aged man. He's tried some dietary things without any effect, and that he's interested in the acidophilus down the road, which is in such a formulation, and that he's interested in how that compares with not doing anything, and that his interested outcome is pain. It's not diarrhea, it's not quality of life, it's pain. And the reason we did that is that because when we do the next step, which is to search, we want to match the question type in the PICO of Jack to the article. We're going to choose our articles based on how well it matches these two things. The other concept that we wanted to bring across, having worked out exactly what the nature of the question is that we have, is what sort of literature there is out there. So we introduced the concept of primary research versus pre-appraised, and we went through the pros and cons of each of these, with the take-home message really being that that if you want to do a proper search, you need to look in all of these, because they've all got their pros and cons. And then we then talked about what sort of search engines would best match what you're searching for, and we talked about the limitations of all these. For example, that PubMed only searches for systematic reviews, and the primary research, that Cochrane's only look at systematic reviews. And we basically introduced the idea that to search all of it, and in the limitations of time, a trip database is not a bad way to go, because it searches for all of those types of evidence, both the original research, the primary that is, and all the pre-appraised, except for the electronic textbooks. Although I guess it does cover Dynamed and some of the evidence-based textbooks. But the idea is that, it's a very good one for quickly searching the breadth of the literature and coming up with what you want. And then we physically went through an article with Jack's question and actually physically found an article showing how to use it. And as I said, I can refer to our YouTube clip for the full detail of how we did that. We then flicked corners and went to the second bit, which is how do you actually read a paper. And we would do this after having a morning tea break, and essentially we went through this structured approach to reading a paper, which I think can work quite well in any quantitative research that you have. I'm not sure about qualitative as such. We didn't really cover that in our workshop. And what we're really doing is looking at the paper and getting people to work out the question type, working out the study design, and we had some great resources so that people could work out what the study design was. There's a nice little flow chart that helps you go through it, because it's sometimes not that obvious. And we also sussed out whether people were familiar with the different study designs, and if they weren't, in that workshop we'd go through those with them. We then went through the PICO of the paper, and the thing I'd like to emphasize about the PICO of the paper is that we did emphasize going into great detail. So for the population, which is the P, we looked at the inclusion criteria and exclusion criteria, and also the baseline characteristics table. So we emphasized those three areas to go for when you're looking for your P. And the reason we emphasized the baseline characteristics table to them was so that they could really capture a feel for who the patient really was that made it into this study. So in this study, now you've only got one or two baseline characteristic tables here, but when you looked at them both together, it turned out being mostly 50-year-old men with either diarrhea or mixed predominant irritable bowel syndrome, that generally didn't have mental health issues, had fairly regular diets, and who didn't smoke much or use much alcohol. And so you're starting to get and there were other details, but the point is you're starting to get a feel for who is this study looking at, so that you can decide whether to apply it to Jack. And we give some examples, and I think the main example we gave is we asked, I say, look, I'm told that the study, that you can't, that rivaroxaban is licensed for use in non-valvular atrial fibrillation. And I say, does that mean you can use it in someone with moderate mitral regurg? And you see what people say. And then you come out pointing out that when you look at the P of the studies for rivaroxaban, that non-valvular atrial fibrillation was defined as anyone except those with severe valvular disease or mitral valve replacements. And that for this reason, cardiologists have no problem giving rivaroxaban to people with moderate mitral regurg. And so it's really just to emphasize the importance of the P. We then go into the I, the I, the PICO, the intervention, and in that we emphasize that you want to go exactly what the dose and exactly what the regime is of the acidophilus, but also what people took in reality, which is always found in the results section where they tell you how many people adhered to it, or they give you some marker of how they, that shows that they actually took what they said they were going to take. And we give the example of the Mediterranean diet versus the American low-fat diet that was that were compared in a randomized controlled study called the Predimed study in people with high risk of cardiovascular events, and with the outcome being cardiovascular events. And we pointed out that, both groups, that the study stated it was Mediterranean diet versus non-Mediterranean versus an American low-fat diet. But when you look at the results, the reality was it was actually they all took Mediterranean diet. But in the study, the researchers had given the Mediterranean group buckets of olive oil, and in another study they gave them buckets of certain types of nuts. And they even did blood test markers that were biomarkers of them taking these things, and that they showed that they were much more elevated in the treatment group. So suddenly what looked like an intervention being Mediterranean diet actually turned out being people who do have lots of olive oil, and in the other study, people who have lots of walnuts and hazelnuts. So they're just trying to show why you go into detail here, basically. And then the main point we made about the outcome was really just that there's primary and secondary outcomes, and how secondary outcomes are only hypothesis generating, and that there should really only be one primary outcome with a few exceptions. And we talk about the reasons why that's the case, and how sometimes it's hard to find what the primary outcome is, but a good tip we gave was go to the sample size power calculations in the statistics section, because that'll really give you an idea of what they powered this study, what outcome they're actually trying to answer. So that was sort of the take-home message there. And so we spent a fair while on those three, because at the end of the day, even if you don't know how to assess the internal validity and the results, if you can do those top three, you can really go a long way in knowing whether you can actually apply this to a patient, and particularly in studies that were well done. That means a GP can get a lot out without knowing too much in the way of epidemiology and research. Now, we then did go into internal validity and results, and we thought we might run the risk of losing people at this point. So what we did is we really just mainly focused on the whole concept of that there's 4 possible explanations of any result. We pointed out that there's the possibility the results are true, chance, bias, or an unequal distribution of prognostic variables. And we said that the whole point, before you look at a result, you really need to know what the role of these other 3 is first. And we pointed out that internal validity deals with these first 2. We defined all these things during the thing. As I said, you can go into our full-length YouTube clip so you can see how we did that. But what we're trying to get across is the idea that internal validity is about dealing with identifying bias and this unequal distribution of prognostic variables. Now you might ask yourself, did we actually use a checklist to go through and actually assess the internal validity? Because as you know, there is a checklist to use, and we didn't really. The main points we made about is that to assess this internal validity, you use a checklist, and that there's different checklists out there for different types of study designs and question types. We gave them one. We used the CASP one as an example, one that they can take home and look at, and we gave them some YouTube clips to show them how to use to understand why they ask the questions they ask. And we also gave them the analogy that that internal validity is like going to a car dealer and looking at a car and looking for dents, seeing if there's any dents. So we sort of just gave them all the broad concepts, and we didn't actually go into a specific checklist with the paper. We then went to results. Again, it's one that you can lose people with. So the first concept I put out there is that by the time you get to results, you should have an idea, having done the internal validity, you should have an idea of what biases there are and what unequal distribution of prognostic variables there are in the study, if any. And then we just broadly introduced a few concepts that firstly, if there was an unequal distribution of prognostic variables, that the result you look at has to have adjusted for that, and that there's a variety of methods that they don't really need to know the full detail of, except they might have heard of terms like multivariate analysis or things with the word propensity score in them, and that essentially these are just ways that you can get a raw result, plug in the unequal distribution of prognostic variables, the various prognostic variables, and come out with a result that takes into account that unequal distribution of prognostic variables. And with the take-home message that when you if you've identified an unequal distribution of prognostic variables, don't go to a raw result, go to that one that's adjusted. And that's all we pretty much said about that at this stage. And then we went through the system of actually how you look at a result. And essentially we just introduced the broad idea, which is essentially, is it a primary or secondary outcome? Because it's the primary that we're chiefly interested in. How is the result expressed? So is it a ratio, like a relative risk hazard ratio, odds ratio, or is it an absolute difference? And we tried to point out the difference between those. We then said that the next thing you do is go to the 95th% confidence interval. We did define that because we thought that would be we think that was a useful one to understand. And then we said that the next step is you decide based on the confidence interval whether the result is a positive study or a negative study. So did it show a difference or not? And then we said that if it's a positive study, that you go to the p-value to see if it's less than 0.05. Whereas if it's a negative study, you don't go to the p-value, you go to the power. So in other words, you go to different things depending on whether it's a positive or negative study. And we pointed out that this is how you deal with chance, the last bit of our 4 possibilities of of a result. So we didn't actually explain we thought it was no point trying to get people to learn what a p-value actually is. More about how to drive a car, like what do you actually, how do you, well, we just went through, if I've got a result, how do you go through it to come out with a conclusion? And so this is why we did that. And then having dealt with chance, we then said that the next thing is you try and make that result more meaningful, which is where you'll start converting ratios to absolute differences to number needed to treat. Or in the case of a diagnostic study, a sensitivity, specificity, you convert to a likelihood ratio, or a positive and negative predictive values, so something more meaningful. And then you can make a conclusion whether it's clinically meaningful. So that was our gist. We did that obviously, and I'd refer you to our YouTube clip how we actually explain this stuff. I quite like the way we did it, but we don't have time to go through that with this 20-minute thing. And the last thing was external validity, and that's about how do you apply this to a patient. And the essential features that we really tried to push home here is does the PICO of Jack match the PICO of the paper? What's the overall harms and overall benefits of this medication, even thinking beyond the paper? And the last thing is, how can I apply this result in the context of the evidence-based triad, which is where we finished up on. And this patient, in the context of what I know about them clinically, and the resources I know we've got locally available, and the patient's expectations. And that's how we finished it.